Well, good afternoon, everyone. My name's Graham Russell, and I'm the Honorary President of the Paget Association, and I'd like to welcome you to this series of video presentations that we're doing on the theme of bisphosphonates for the treatment of Paget's disease. And they're going to be used for the celebration of the Paget's Awareness Day on the 11th of January next in 2021, which marks the 207th birthday anniversary of the birth of Sir James Paget. And today I have the pleasure of welcoming Professor Stuart Ralston, who's chairman of our trustees, who's very kindly agreed to talk to me today mainly about clinical trials that he's conducted in the treatment of Paget's disease with bisphosphonates. Stuart and I know each other very well, but I'm going to ask him in a minute just to tell everyone about his career and for those who don't know him. But many of you will know that he's contributed enormously to understanding the genetics of Paget's disease. But today we're going to talk more about the trials and treatment. So Stuart, can you tell us a little bit about your background and academic career?
Thank you, Graham. Yeah. So I'm Professor of Rheumatology at the University of Edinburgh currently, and I graduated from Glasgow in 1987. And actually, I developed an interest in Paget's when I worked at Glasgow Royal Infirmary with Ian Boyle in the late 1980s, and that has stayed with me ever since. And I've been conducting research and seeing patients with Paget's disease for the past, 30 years, I guess. So.
Yes, Stuart, so you're still a youngster, really. Well, we always think of you as a youngster. 30 years is a long time, and maybe we could take you back to one of the trials that's had a huge impact, which is the Prism Study, which you have a reputation, a good one, of doing some of the largest clinical trials in very difficult areas. This was a clinical trial of the treatment of Paget's disease, the Prism Study. And maybe you could tell us about what that study was about and, why you felt it was necessary to do it.
Thanks, Graham. Yeah, so the reason we did the Prism Study, I was working in Aberdeen at that point in time. And I guess people of my generation, we had been brought up believing that you needed to suppress bone turnover in Paget's disease because that would improve the outcome of patients. And the Prism Study was really designed to see if that was the case. So we enrolled 1,324 patients with Paget's. It's the biggest, I think, clinical trial that's ever been done in Paget's. And we randomized them to what's called intensive treatment, which at that time would have been with risedronate, because that was the most active or the most potent drug available, versus standard care. And in standard care, the clinicians were advised, treat the patient, do not treat the alkaline phosphatase. Whereas in the intensive group, it was treating the alkaline phosphatase. So if you like, it was a treat to target strategy designed to ask, if you really tried to suppress the alkaline phosphatase, was the outcome improved? And what it showed, to my surprise really, and also to many people's surprise, is that having a treat to target strategy or intensive bisphosphonate treatment, it didn't really improve outcomes. So the number of patients with fracture was the same. With pagetic fracture, again, it wasn't different. The number needing joint replacement for osteoarthritis wasn't different, and the pain and quality of life was similar. So it was an important study because it showed that you don't need to flog the patient with lots of bisphosphonates to get a good outcome, but just giving bisphosphonates from time to time to treat symptoms was as good as intensive treatment, and that's what the study showed, and that's what I've been doing ever since, really.
So many thanks, Stuart. I mean, Prism really showed, I think, as you said, much to everybody's surprise, that maybe the way that people had approached treatment needed a rethink, and the strategy based on controlling symptoms was probably more important. So can you give us some more thoughts about that?
Yeah, I mean, when we look back at the Prism population, they were a heavily treated cohort. I think 60% had been treated with bisphosphonates before. And I should emphasize, it wasn't a placebo-controlled trial. It's comparing two different treatment strategies. So not to say that bisphosphonates weren't effective, but it told us a little bit how they should be used. And the average age entry to the trial was mid-70s. By that time, the patients had been known to have Pagets for at least 10 years, and actually probably had Pagets for a good bit before that, maybe 15 or 20 years actually. And just knowing the patients that I enrolled and looking at the characteristics of them, a lot of them had osteoarthritis, a fair amount had deafness, a fair amount had deformity. And what we thought was that, well, maybe it was too late by that time. You know, maybe by the time you'd been 10 years into the diagnosis and probably had the condition for maybe 15 or 20 years, is that it was too much to ask for this treat to target strategy to really make a difference. And then maybe we should go in earlier. And it kind of led to another trial called the ZIP trial, which I'd be happy to tell you about. But that was the bottom line. We felt that by the time you had established Paget's disease, there was a limited amount you could do, and that maybe we should be trying to go in at an earlier stage in the disease process. Yes,
before we move on to that, maybe you could just talk about the Prism EZ study, as you call it, because zoledronic acid, you know, has emerged probably as the preferred bisphosphonate among the ones available. And in your first Prism, you didn't have that included. So maybe we just comment on that aspect, because, you know, that most patients these days, if they get a bisphosphonate, would have the zoledronate. I call it zoledronate. Others call it zoledronic acid, but it's the same.
Thanks very much, Graham. Yeah, the Prism EZ, as I call it. Yeah, and as you said, when the trial was designed, I think it was around 1999, risedronate was the most potent drug available, and zoledronic acid was kind of had been developed, or was starting to be developed at that point, but it wasn't available. And so after we finished ZIP, we thought, well, now that zoledronic acid is available, then it would be really good to try that, to see if it made a difference. And so basically it was, the patients were followed on. If they were in the symptomatic arm, we continued to treat them symptomatically. If they were in the intensive arm, they got switched from risedronate to zoledronic acid as the treatment of choice. I mean, what that showed was, as we know with zoledronic acid or zoledronate, the bone turnover got suppressed, so it was more effective than risedronate at suppressing bone turnover. But again, we didn't see a benefit, and like as I've hinted, it could have been that, you know, again, they were late 80s by this time, or late 70s by this time. It may have been too late to see reversal of the complications. I should say the Prism EZ, there was a fair amount of attrition by the time patients got to that stage, but it was still a big study. And so again, both strategies were equivalent. There was a hint that there were slightly more fractures and slightly more joint replacements in the zoledronic acid arm, but the numbers were quite small. And I could say that it certainly didn't benefit having zoledronic acid, but it was equivalent, in fact, to standard care, if you like.
I mean, there's still an important issue about, you know, when you treat patients. And I think your overall conclusion, if they're symptomatic for pain, then that's the time at which you will give them a bisphosphonate.
Yeah, I think that's right. And I'm a rheumatologist, as you know, Graham, and we have the same thing with disease modifying drugs in rheumatology. If you wait until the time that erosions have developed, that, you know, suppressing inflammation at that time can only do a limited amount.
Yes.
And I think it's analogous to Paget's. Once the bone is deformed, once you've got osteoarthritis, very, very difficult to reverse that. So that's where the kind of treat earlier idea arose, basically.
Well, you haven't been deterred by any of these mega efforts you've made. And the trial you're currently conducting is called ZIP. And I mean, that's a very impressive design, which will probably only ever be done once, I would think, because of the challenge of doing it. So maybe you could tell us a little bit about the rationale behind that and what you found so far.
Thanks, Graham. Yeah, so the ZIP trial, which stands for Zoledronate and the Prevention of Paget's, as I say, got born out of the idea that these drugs are very potent drugs. Surely they must be doing something. And we thought it would be good to start at a much earlier stage in the disease process. So with ZIP, what we did is we focused on people who tested positive for a gene mutation in a gene called sequestosome 1. I've done a lot of studies on the genetic basis of Paget's, and sequestosome 1 is the most important gene, if you like. And so what we did was we tested people around about 50, the average age was 50, and if they were positive for the mutation, we randomized them into zoledronic acid or a dummy infusion. So it's what's called a double-blind randomized control trial. The study is still in progress. We should have actually finished already by now, but the dreaded coronavirus has intervened, regrettably. We're about 3/4 the way there, but we have sites in London, in Italy, in Spain, and in Dublin who haven't quite managed to do the closeout visits. And I mean, what I can tell you about the ZIP study is we have analysed the baseline data, and about 10% of people in the ZIP study at baseline had Paget's bone lesions on bone scans. So these were people, they were children of people known to have Paget's, they were positive for sequestosome, and 10% of them had Paget's disease but didn't know it. So this was really at the earliest stage in the disease process. I've been going through the scans. Some of them have got worse, some of them have got better. I don't know who has got what. I'm hoping the ones that have got better were randomized to zoledronic acid, but I'm blinded, needless to say, at the moment. So hopefully that will give us an answer if we manage to get everyone in. And what I'm hoping it will show is if you intervene early, that this potent drug, which Ian Reid talked about earlier in this series of interviews, you know, really will make a difference if you give it at the right stage.
Yes, it's very interesting. It's a very ambitious study, and let's, you know, hope there's a clear result from it. I mean, it's such a shame that it's been impacted by the coronavirus, and I guess to a certain extent it might be vulnerable to Brexit as well. You know, because you have European centres involved and so on.
Yeah, well, what we've had to do actually, and we're doing it with another trial, is that with the legislation, if you have a trial, even though it was many years ago since the medicine was administered, you have to have a sponsor in Europe. And I'm glad to say we've done a deal with University College Dublin, or UCD, and they are the European sponsor. And so, COVID willing, if things calm down a bit, we'll manage to get those last few patients in, and we'll hopefully have an answer. I was hoping we'd have everyone in before Christmas. I think that's now vanishingly unlikely, but hopefully in the first quarter of next year, things come under more control. We'll get there in the end. I certainly hope so. It's been a stressful past few months, I can tell you, but I'm trying to remain positive.
Yeah. Well, Stuart, thanks very much for your time talking about this, and I'm sure everybody will appreciate hearing your views. Now, maybe to finish with, do you have plans for the future? What do you expect to be doing next?
Well, in anticipation of the ZIP study showing something, I think that I believe that picking up the disease at an earlier stage is a key thing. And we know from genome-wide association studies, genome sequencing studies, a lot of genes that predispose. So the study, I'm doing 2 studies. One is following up the ZIP patients long-term. That's called ZIP long-term extension, or ZIP LTE. That's in progress. And the other one I'm doing is called GAP-DPD, where we are now able to test for all the variants that predispose to Paget's, and pick people up early on. And that may give, although that's an observational study, it may give us the opportunity to pick people up and offer them early treatment. So that'll take me another few years, but it'll keep me busy till my retirement, I think.
Well, I didn't think you were ever going to retire. I mean, for the benefit of sufferers listening, how many of them have an identifiable genetic cause these days?
It's difficult to say. With sequestosome, it is an inherited condition. If you're positive, it's thought that you will almost definitely get Paget's. With the other gene loci, it depends on having maybe 1 or 2 or 3 variants that predispose you. And I suppose that's one of the points about the GAP-DPD study. We hope to quantify that. The other thing we've been doing is looking at what's called epigenetic signals with my colleague Omar Al-Baga, and that looks very promising for picking people up. So I think early diagnosis seems to be the key, and in the next 5 years, I'm hoping we're going to be in a position for people who have a parent with Paget's or a relative to actually give an estimate of their risk and either reassure them or maybe put them into an enhanced surveillance program. So I see that's the way things moving in the future.
Stuart, it's been a pleasure talking to you, and thank you very much for your time today.
Thank you, Graham. It was a pleasure to talk to you. Bye-bye.